Today's lecture is going to be on immunity and the immune system and how it works. Basically a review of things that you already learned in term 3, but we need to kind of recap it. So the learning objectives here for this chapter are going to be, when you get a vaccination, what kind of immunity are you obtaining? What are the mechanisms of immunity? What are immunoglobulins and what do they do as far as immune response is concerned? How does aging affect the immune response? And then we're going to talk about how you do assessments, subjective and objective data, what kind of care you have to provide for patients that are having tests for the immune system, and then what kind of therapeutic measures do we use to treat patients who have immune disorders, okay? So first we'll talk about the immune system in general. So the immune system consists of your lymphoid organs, lymphocytes, white blood cells. There are chemicals involved in the response like cytokines. And then your lymphatic system, which is your lymphatic vessels, your lymph nodes, lymph fluid, and your spleen, which is considered to be an accessory organ or part of your lymphatic system. If you look at slide number 5, it does give you a really nice diagram that shows you the tonsils, the lymph nodes, the nodules, etc., throughout the body and where clusters of nodes are. So you'll see that the cervical lymph nodes, axillary, and inguinal, they're the ones that are palpable when they're enlarged. The skin at the cervical spine right here at the neck and at the axilli and at the inguinal area is thin. And so typically, because of where they're located and the fact that the skin is thin there, they're more easily palpable. You also have a cluster of lymph nodes in the middle of your chest by the mediastinum. And those, even though they're not palpable, they are distinguishable with diagnostics like CT scan and MRI. And they tell us information about, the certain disease processes when they are enlarged, swollen. So let's talk about antigen antibody. And again, this is kind of a recap. Antigens are pathogens. In other words, a virus, a bacterium that gets in, and it's a chemical marker. It's almost like they're wearing a sign when they get into your body. So if you're exposed to an antigen, say a virus like the cold or the flu. So when they enter your body, they're wearing a sign that identifies them as something that's not part of you, right? The antigens wear a sign. Your cells have your own antigens, and they wear signs that go, don't hurt me, I belong to this body. But the foreign cell antigens don't match. And so your white blood cells will look at them and say, hey, wait a minute, they're foreign, they're not supposed to be here, kill them, destroy them, okay? So antigens are just pathogens, basically. And then for your white blood cells, you've got different types of white blood cells. The first ones we're going to talk about are your lymphocytes. And I've always loved the name natural killer cells. I just love that name. So your lymphocytes have different types of cells under the umbrella of lymphocytes. And under that umbrella, your natural killer cells, they're the cells that go out and literally kill foreign things that come into your body, like pathogens. And then you have thymus-derived lymphocytes, T cells. T cells are trained in the thymus when you're a child. And we believe that with autoimmune disorders, and we don't know this for sure, but we believe there's a hypothesis that's widely accepted, that something goes wrong when those T cells are getting trained in your thymus gland when you're a child, and they cannot differentiate or recognize what belongs to you and what's a pathogen or an antigen. And that's why autoimmune disorders, these killer cells and some other, different T cells will destroy your own organs, tissues, skin, cells, okay? And then you have bone marrow derived lymphocytes. So T cells from the thymus, B cells come from the bone marrow, and they match thymus T, bone marrow B. And then under the natural killer cells, you have them in your blood and your bone marrow, your lymph nodes, and your spleen. And they destroy pathogens, some tumors. When we get to cancer, you'll understand that most cancers are your own cells that mutate. And when it happens, the body can't differentiate them from normal cells. So that's why your immune system is not sufficient as a response to cancer. Okay? All right. So we'll continue. When we talk about the T cells and the B cells in the lymphocytes, they have specificity, right? So in other words, they respond to one particular foreign body or foreign antigen. So the T cells reside in your lymph nodes, nodules, and spleen, and the B cells are the ones that produce antibodies to very specific antigens. They're the memory cells. So in other words, give you an example. I had the chicken pox when I was a child. So I had the chicken pox, the varicella virus, and once I was infected with it, my body, because my immune system was working the way it's meant to work, recognized that virus as an antigen, okay, as a foreign object, and I produced antibodies specifically for varicella. And they remember. That's why we call them memory cells. So if I ever get exposed to varicella again, I have these antibodies that say, oh, varicella, kill it. And so I will not become ill again with the same disease. Okay? And when we talk about antibodies and everything that happens with our immune system has to do with this antigen antibody response. Okay? There are plasma proteins that you have in your blood, 5 of them actually. But the ones that are really important that you need to know about and the ones that you may get asked about are your IgG and your IgE. Okay? So immunoglobulins or gamma globulins are the proteins that the plasma cells make to respond to these antigens, and they are specific, right? And they label them for destruction. They don't actually do the killing, but they recognize. So if I get exposed to varicella, my antibodies that are in my immune response, my IgG, that are specifically for varicella, will go out and say, ooh, varicella virus. And they'll actually stick a sign on that virus so that my T cells can go kill it. So it's kind of like having a monitor and then a whole squad of killers. So the monitor decides that something doesn't belong, puts a label on it, and then the white blood cells go kill it. And so the 5 classes of antibodies that you need to know about, you don't need to know all 5, again, just the 2 of the 5. IgG and IgG is about immune response. That's all it is about. IgE is all in response to allergies. Okay? So just remember that IgE, allergy. IgG, immune. Okay? And remember, each of these antibodies are specific for one antigen. So I either have the antibodies or I don't for varicella or for the measles or for the mumps or any of these diseases. Okay? All right. So, you don't really need to understand how they're formed, so I'm not going to get into detail about that. And I'm even not going to get into detail about the difference between cell-mediated immunity and humoral immunity. That's really not that critically important right now. But I do want to get into detail about the way the antibody response happens. So I'm going to move forward to slide 17. And so you're exposed to a foreign antigen, gets into your system, and that stimulates the antibodies to start reproducing, right, in small amounts. A second exposure to the antigen will cause the memory cells to make big amounts of the antibody. And that's how vaccines work. Okay? And this is really where this whole conversation is leading to, what happens when we get vaccinated? How does a vaccination work? Okay? And so I'm going to talk about the kinds of immunity that can occur based on either naturally acquired or artificially acquired immunity. Okay? So naturally acquired immunity means that you get it either from your mom when she's pregnant with you. Okay, so the newborn baby has naturally acquired immunity for about 6 months. So in other words, if mom's immune, baby is too. And then also breast milk, and especially colostrum, which is that yellowy substance that's in the beginning before the milk actually comes in, is loaded with antibodies from mom that help protect the newborn. So that's naturally acquired, right? But it's temporary. The one thing to remember about passive immunity doesn't last, okay? It is temporary, okay? It's going to wear off. That's why we start vaccinating babies pretty quickly, right? As soon as they're born, really. And then artificially acquired is the injection into someone of preformed antibodies. In other words, so I'm going to use this coronavirus pandemic that we've got happening right now as an example. You've been exposed to COVID-19. Oh, barking dog. We're going to have to pause this first. Sorry about that. So, you have been exposed to COVID-19. You may or may not have been symptomatic. You may or may not have been ill. But your level of exposure, in other words, were you right up close with someone who had it and maybe, you didn't know? The level of exposure, in other words, how much of that virus was able to get into you will determine the amount of antibodies that you produce, right? With passive immunity that's artificially acquired, what we do is we take someone who's been exposed and now has the presence of a large number of antibodies in their blood. And that blood test, by the way, is called a titer. If you remember when you started here, you start nursing school, you have to get titers. You have to get them for your MMR, measles, mumps, and rubella. So what we're doing is we're looking at your blood to see if you've got the antibodies, sufficient numbers of antibodies to protect you from getting the measles, the mumps, or rubella. And so if you have these antibodies, and again, let's go back to COVID-19. So now we test your blood and you have the antibodies, large numbers of them. We can take them from you. And it goes through a process, which, we're not going to get into the details about the process, but we can then take those antibodies and inject them into someone to give them temporary, passive, artificially acquired immunity, okay? So basically it is giving someone antibodies that are already made from someone else that will provide that person receiving them with immunity that's temporary. Another good example would be if you're going overseas, you're going to a country where there are diseases present that maybe we would not see here in this country. And so you typically wouldn't get vaccinated for them. But you're leaving in 2 days. So what do? We can give you a vaccination that's actually just injecting you with ready-made antibodies so that you are instantly protected against specific diseases. But remember, it's temporary, so it's going to wear off. So passive immunity, ready-made antibodies we're giving you. It's only temporary. You can get it naturally, like from your mom. You can get it artificially from an injection, okay? And then we have active immunity. So active immunity is where your body is making its own antibodies, okay? Your body's making its own. Now, this takes a little bit of time. The example that I'll give you is when you get your annual flu shot. When we give you the flu shot, what we're actually injecting you with is a covalent, inactivated, attenuated, in other words, a dead flu virus. It's not active, okay? So it's not really you can't get the flu from the flu shot. It's not a live vaccine. But it's just enough of that inactivated or attenuated virus that your body, if your immune system's working the way it's supposed to work, recognizes it and will produce antibodies. And the production of the antibodies takes about 2 weeks. It's not instantaneous. It's not bippity boppity boo, boom. So if somebody says, I got the flu shot and then I got the flu, I call bullshit. Why? Because it doesn't work that way. It's not a live vaccine. You don't get sick from it. And it takes about 2 weeks for it to actually, have your body create a response to it. So you can get that artificially from an immunization vaccine, like we talked about. You can get it naturally by getting the disease, like I talked about earlier. So I have memory cells to varicella. So I will not get varicella if I'm exposed to it, okay? And I've been vaccinated against measles, mumps, rubella, polio, diphtheria, tetanus, pertussis, yada, yada, yada. The list goes on and on. I have sufficient antibodies that I've either acquired naturally, like varicella by getting sick, or artificially, like MMR and polio and Tdap, by getting the vaccine. So active immunity used to be thought to be forever. Like we thought that if we gave you the series of Hep B, the 3 injections, that you were good for life. Well, now we know, again, evidence-based research, that there's a theory of waning immunity. In other words, for some people, years and years go by and the number of antibodies can go down, but it's still considered long-lasting. So active immunity, you're making your own antibodies and it's long-lasting, sometimes very long. I got my last MMR as a child, and when I had titers done about a year and a half ago, I still have antibodies, right? So long-lasting active immunity, long-lasting, okay? And it's either artificially acquired, that's how vaccines work, or it's naturally acquired. You got the disease and now you have immunity, okay? Make sure you know that. When we talk about aging and how aging affects the immune response, it's just like everything else with the aging process. You know, as the body ages, everything slows down, right? So, your immune response isn't as quick to respond. It's not as efficient. And so people can get infected more frequently when they're older. I say the very old, the very young, they're fragile. Autoimmune disorders, certain autoimmune disorder numbers, statistically, we see them elevated with older folks because sometimes the theory is that the body's protective mechanisms can get a little confused, okay? And we also see a higher incidence of cancer in aging populations. And the jury's still out on that one. I just want to say that. So just understand with aging, you're more vulnerable to infection, right? Okay. I want to move ahead to immune system assessment because the Board of Nursing and ATI is going to ask you about vaccinations, okay? So before you give any vaccination, you're always going to do an assessment. You're always going to get your subjective and objective data, physical examination of the patient. And of course, you're going to get a health history, a family history, occupational history, and all the information that you need to make sure that there wouldn't be some type of contraindication to the immunization based on an allergy, right? Or those types of things. I want to make sure that the list of immunizations and your understanding of them is concrete at this point. So that's really what I want to focus on at this stage of this lecture. So, in other words, here's what we're going to start talking about. When it comes to immunizations and the immunizations that you need to know. So you need to know the MMR, right, which is measles. And the other name for measles, by the way, if you don't know this, you need to know it, is rubeola. Measles is rubeola. Mumps is still mumps. And rubella is the German measles. Now, do not confuse rubella with rubeola. They are two different diseases. The measles and the German measles are not related. They're different diseases, okay? And you should know that the MMR vaccine is a live vaccine. So in other words, instead of giving the patient a vaccination of an attenuated or inactive virus, we're giving them a little bit of the live virus. And for all of us that are healthy and have good immune responses, and we're not immunocompromised, it's not a problem, okay? Not a problem. However, if the patient is HIV positive, if the patient is pregnant, if the patient has cancer, and not because of the cancer, because of the treatment for the cancer, if they're receiving chemotherapy or radiation therapy to treat the cancer, that suppresses the immune system. So those people would not be candidates for live vaccines. Pregnancy, no live vaccines. HIV positive, no live vaccines. Anybody that's immunocompromised because they're receiving chemo or radiation due to cancer, no live vaccines. And then one more thing I want to add. Long-term use of corticosteroids like prednisone, methylprednisolone, they will suppress your immune response. And so those people are not candidates for live vaccines either, okay? So which vaccines are live? Easy to remember. It's your MMR2, which is measles, mumps, rubella, and varicella vaccine, and your Zostavax, which is the vaccine for herpes zoster, otherwise known as the shingles. Okay? Those are the only live vaccines that you need to know about. Okay? All right, so this one's almost done. Let me wrap this up by saying when we're talking about the immune response to allergies, things that are harmless like hay fever, an allergy is a hypersensitivity response to a benign substance. In other words, it is a response by the body, only in certain people, and we're not sure why, to things that are harmless. I have seasonal allergies like hay fever. So pollen never killed anybody, but when spring comes and the pollen's out, my eyes start to itch and my nose will start to run or get itchy. So it's a hypersensitivity response of histamine to something that really doesn't bother anybody for the most part. But then there's some allergies that can be deadly when we talk about things like nut allergies or allergies to bee stings. Those are things that can be deadly, food allergies particularly. So if somebody has an allergy, we tell them wear a medical alert bracelet, especially if they've had a reaction before. Subsequent exposure will cause a worse reaction. So we might be dealing with anaphylaxis. You always need to assess patients' allergies, and if they do have an allergic or anaphylactic reaction to anything, a med, whatever, epinephrine, the EpiPen, that's what you need to know. Please, please make sure you understand how to administer the EpiPen. They should always carry an EpiPen with them if they have an allergy that can be deadly. And that EpiPen, the expiration date needs to be checked. And then, where do you administer it? That EpiPen can be popped open and basically administered as an IM injection in the leg. It's a quick fix for what could be a life-threatening situation. Anaphylaxis is an extreme histamine response. It's an allergic response that causes severe angioedema about the face and throat. The tongue will swell. The oral mucosa in the throat will swell, which will constrict the airway. And the patient, could die. So, all right. When we talk about the vaccines, again, I want to finish with the vaccination list and the ones that you really, need to know. With vaccinations, you need to know the live vaccines, MMR, MMR2, varicella, herpes zoster. And you also need to know who should get them, who shouldn't get them. Okay, so MMR, get a series of 3 when you're an infant and a child. Varicella, 1 dose. Herpes zoster is recommended for all of those people over the age of 60, but not if they're immunocompromised, right? So, and then the other vaccinations that are not live, your Tdap, which is tetanus, diphtheria, and pertussis. Pertussis is whooping cough. Tetanus, by the way, is lockjaw. It comes, one of the diseases that comes from getting some type of an open wound, a laceration with, say, a rusty nail, and it affects the neurological system. And with tetanus, you literally, your jaw will lock up on your heart, so you won't be able to move it. That's why it's called lockjaw. So Tdap is every 10 years. It's not live. HPV, the human papillomavirus, 11 to 26 are the recommended age groups, male and female, because HPV we now know is linked to cervical and some other types of cancers. The annual flu shot, everybody should get it. They absolutely should get it if they're immunocompromised. So if somebody has a chronic disease like COPD, their priority, they have to get their flu shot, okay? And that's yearly. And then the pneumococcal pneumonia is a one-time dose, right? And usually recommended after the age of 60. And then the hepatitis B series, it's a series of 3 immunizations. You get your first, 30 days later you get your second, and then 6 months after the first you get your third dose. And that's only given to those that are considered to be at-risk populations, like us, healthcare workers, right? Who are going to potentially have exposure to blood and body fluids. Okay, so make sure you know which ones are live, which ones are not, and why people that are immunocompromised or pregnant can't have the live vaccines, okay? And how, patient education. that's all I have for this one. So we're going to end this and say on to the next one. All right, bye.